Okay.
Next, we call on stage Dr. Chitra Ramamurthy. She is the medical director of the Eye Foundation Group of Hospitals. She is a prolific cataract, glaucoma, as well as a refractive surgeon. And she's going to talk to us about control of astigmatism after cataract surgery or during cataract surgery.
Is my thing connected?
Yeah, we can see.
Yeah. Very good morning to one and all of you. My very special thanks to Santosh and all the moderators on the dais and my dear audience. I would wish that you hear each of these and please come up with queries. I'll try my best to explain. So my due in the next 15 minutes to talk to you about astigmatic management during cataract surgery. Basically, why do you want to correct astigmatism? Because we have realized that even a residual astigmatism of more than 0.5 brings down the quality of the image. This was a study done of 7,500 eyes of cataract surgery patients, wherein they found that there were 25% of them who had moderate astigmatism and about 10% of them had more than 2 diopter of astigmatism. So you do just a cataract surgery and a monofocal, you have punished that patient to wear spectacles for distance throughout his life. Whereas if you are addressing the astigmatism, you are giving him some amount of visual independence for distance. So what is the best procedure to correct astigmatism cataract surgery? So this table comes up, either on-axis incision making or do an LRI or an astigmatic keratotomy or a toric IOL, or after the surgery, if there's a residual refractive error, do a laser correction or give him contact lenses, or he is happy with glasses. So these largely, finally, these are the 4 things which are practiced for astigmatic correction after cataract surgery. Now, when I say incision on the steep axis is after making your 2 side ports, there was a belief that if you make an incision on the steep axis, it will bring down the astigmatism by 0.5. But nowadays, we understand the term called the centroid value, wherein it has calculated that for any incision less than 2.4, the astigmatism induced is only 0.1. And if your incision is going to be more than 2.4, then max astigmatic 2.8 maybe, then the astigmatic impact could go up to 0.3. So nowadays, there is absolutely no need for us to measure or calculate our surgical induced astigmatism. There are 2 other possibilities, the limbal relaxing incision and the astigmatic keratotomies, which can be done for small amount of astigmatism. These are incisional procedures, and again, they are made approx in the 90% depth in the steep axis. LRIs are made as either 1 or 2 coupling incision on either side of the axis, as I'm going to show you. And essentially, you need to measure the amount of astigmatism and axis of astigmatism and feed it into different nomograms. The Dornan-Wien, the Nichamens nomograms are all available online, and it will tell you exactly what is the arc length of these incisions to be made on the limbus and what should be the depth it has to be made. And you should also identify the pachymetry at that intended side of incision. So now this is one manual way, like wherein you're marking the limbus, that is the clock hours of which you're going to be incising at the limbus, just anterior to the arcade. And this is done at the diamond knife is calibrated to go to the depth of 600 micron, and an arc-like incision is made in that measured clock hour. So these are different tables which will tell you how much of the clock hours you're going to incise for different astigmatism, what is the incision for with the rule and against the rule. Just to give you a pictorial thing, now this is a Varion overlay with which you are marking the axis, and again with the diamond knife and arcuate incision is being made. What you need to understand, arcuate incisions on the next, which I'm going to talk, are made at actually as you're going to see after doing the arcuate incision are little mid-peripheral at 8 millimeter optic zone or 9 millimeter, and these have a better astigmatic impact than the limbal relaxing incision. But all these incisions, there is regression, there's wound remodeling, so they are not exactly very optimal. So when you talk of being optimal and exact, we need to look at the toric IOLs. For the toric IOLs, we need to first measure the amount of astigmatism on the cornea. We need to feed in the right formulae. We need to mark the axis where you're going to place the lens if it is a manual way, and we have to align it on the correct axis. It is most important that it is an orthogonal regular astigmatism and not non-orthogonal or not an irregular astigmatism. The cornea should not be dry. It should be healthy ocular surface. If it is dry, you need to treat the dry eye, then do your biometry, and then do a toric implant. So some of the pearls are, when a patient comes for a cataract counseling in our center, we first put them on a toric calculator to understand whether the patient has astigmatism, and then take our discussion. Do you want to have a toric IOL or monofocal? And he would understand what is the level of correction he's going to get for distant vision. Barrett toric calculator is an excellent tool in this matter. We also need to understand whether it's an against the rule or with the rule astigmatism. We need to understand that the posterior cornea is against the rule in 90% of the situation, and if the anterior cornea is with the rule, naturally this gets subtracted, and the amount of total corneal astigmatism is less. If both anterior and posterior are against the rule, then the total anterior corneal astigmatism is low. So next is the threshold. Now, what interesting thing you understand is, if it is a 0.9 with the rule and 0.88 against the rule, you will find that the toric calculator will say to correct the 0.88, because the posterior cornea has to be accounted for, and I said 90% of the time the posterior cornea is against the rule, so the two get added on, so the magnitude of astigmatism is more. So then it tells, again in this, the 0.75 against the rule, the toric calculator gave a toric power, but for 0.75 with the rule, it said no toric IOL is needed. Then this was a patient who underwent actually, had a small amount of astigmatism. We went at that time, there was no panoptics toric. We fixed a panoptics for him. He had a small residual astigmatism. So what we did was, the next time we did a panoptics toric for him. I'm not showing you the video. And then he had great vision. And then we took this patient back and did a laser vision correction for the residual error in the first eye. And he had a plano 6.6 in both eyes. So what you understand is, when you are planning a multifocal IOL, even from 0.75 diopter of astigmatism needs to be corrected for the patient to have the visual gains which a multifocal promises. If the astigmatism is small, 0.5, 0.6, this is when you could do an arcuate incision, as I had shown you earlier on, an incision which is made on the mid-peripheral cornea. It can be manual arcades, but nowadays if you're on the femtocataract platform, the arcuate incisions are made by the femtosecond laser. So the next thing is the accuracy of measurements. So essentially, biometry is simple arithmetics. There are some assumptions, there are some actual values. So when you feed in that you want to target emmetropy of this value, the things which come up are axial length, the K value, and the effective lens position. Today with the optical biometers, our axial length measurements are bang on, but the K values are variable in different machines, so there are some assumptions there. And where the lens is going to sit in the capsular bag is the effective lens position. Again, there are assumptions there, and with some sure values and assumptions, your final power is decided. So it becomes very necessary that you have the best of equipment possible, or understand everything about that equipment in detail. We have a dedicated technician who will pick up those false positives and those issues, and you ensure that you are looking at taking multiple readings, repeatability of readings, and using the latest or the 4th generation formula to get in accuracy, especially in extremes of axial length. We have different biometers, which I'm sure has been discussed with you all. But what happens when we talk of K reading? I had said there are variables, because the manual K measures at 3.2 ring, the IOL master has 3 rings, the lens star has 2 rings, so there are variables. How close to the center you are able to measure the K value, that accurate it is. And if you have dry eye, there could again be fallacies. So whenever you take a K reading, if you have another modality, measure in that, see whether there's repeatability in the measurements. Again, it's very important to even compare the two eyes. Now in this, one eye has an axial length of 27, other has 25. Do we just presume that it is a small axial length? Then we should have discussed amblyopia, probably because of the difference in power. But it is better to validate your measurements and repeat the measurements in the same instrument or with another instrument. This was done on immersion, so you look carefully whether all the spikes were equal, remove the outliers, keep the 5 best reading, and take the right appropriate value. Even if the other eye is pseudo-phakic, you will get a lot of information about the anterior chamber depth and K values, and you need to basically understand that if the K value between the two eyes is more than 0.3, 0.1 diopter, axial length is more than 0.3, IOL power between two eyes is more than 1 diopter, we need to repeat measurements. Now this was a case of dry eye. One eye it showed as astigmatism 0.5, other eye it showed at +2. When you looked at him at the slit lamp, there were a lot of big epithelial erosions. So you treated the dry eye, and then when you repeated your measurements, it was only 0.2. Supposing I had not seen the patient on the slit lamp, supposing I had not evaluated the dry eye, astigmatic calculation would have been different. Again, this patient had 1 diopter in one eye and 0.3 in the other eye. There could be an artifact, could be a Dellen there, but if you look carefully on those Myers, though it had a fishtail appearance on those, so then you realize it's dry eye and you treat the dry eye. This was a case wherein the patient had 1 diopter of with the rule astigmatism and the other eye 1 diopter of against the rule astigmatism. And then when you looked, that one eyelid was pressing down, and if you put a tape and retract that eye and then eyelid and take the measurements, then it was found that both eyes had similar astigmatism. This was a case of a pellucid marginal degeneration, and generally the central cornea is quite good. So you could take those values and there will be a high astigmatism. You might have to fit a customized IOL. In a case of a keratoconus, again, there are different formulas. We have the Keynes formula, the Barrett's formula, the SRKT formula. Basically, both the anterior and the posterior cornea are altered. So we need to have specific formula which is going to compensate for that. It's beyond the scope of this talk to discuss, but you need to use the right formula. And then, even though the cornea is not exactly very regular, but after the DALC procedure, you are able to get your measurements. He had a 6 diopter of astigmatism, and we were able to debulk it to 2 diopter. We have at least improved his BCVA for this particular patient. Then again, we go on to the next situation. A patient has a pterygium with a high astigmatism. So then we have to go ahead and operate on the pterygium and wait for a period of 6 weeks, and then repeat the measurements, and then implant a toric IOL or a monofocal as it may demand. It is very important that you look at the standard deviation when you're doing your measurements, and if the standard deviation is more than 2 diopter, the signal to noise ratio, you look in these biometers, look whether the foveal pitch was visualized, whether the fishtail appearance is there, whether the spots. If it is, you see that the standard deviation is more. What will I do? Think of dry eye. Look for dry eye, evaluate for dry eye, and if the dry eye is there, treat it, then repeat your keratometry. If it's not dry eye, it could be keratoconus, it could be a refractive surgery eye, then you may have to do a tomography and then find out. And after find out, feed it into the toric calculator and will tell you what is the toric IOL power and what is the axis of astigmatism. So when we talk of, once we know it's astigmatism, you need to use toric calculators, ones which measure the posterior corneal astigmatism, which measures the toricity ratio. That is the ratio of the astigmatism on the cornea to the IOL plane. And you just feed in a standard value of 1.45, it won't help, because a myopic eye has a different toricity ratio because it's a deep axial length, whereas a hyperopic eye has a small axial length and a small anterior chamber depth. Again, the centroid ratio we need to know, as I had already alluded to. And so it becomes important that all these are factored in, and the different calculators have these values. Taking you further, we need to nail the axis. Like you can either measure the axis 3 o'clock, 9 o'clock on the slit lamp by placing your slit beam centrally, or you could measure with a bubble marker. There are different ways by which you could measure it. I think it's a talk which needs half an hour. You could, if you have access to eye trace, that will help you to measure the axis of placement. And once you've done it manually, you could use a Mendelssohn's thing and a toric marker, and thus you are able to do it. If you have a Varion overlay, it will come, the overlay will come, and it will tell you after removing all the viscoelastic how to align it onto the dots. If the IOL is rotated, now what you need to understand, if the toric IOL rotates only 1 degree, there's a 3% loss of correction. Whereas if the toric IOL has rotated more than 30 degrees, it is actually going to increase the residual astigmatism, what more than what the patient had. So then it is more in higher amounts of astigmatism. Like a person has +2 diopter of astigmatism and the residual, the loss of astigmatism would be more. So it is also important in high minus powers, the capsular bag is big. So you may wonder whether you need to place a CTR in these eyes for a stability of the toric IOL. There are better quality lenses which adhere to the posterior capsule, have a tackiness about them, and these are more optimal for toric IOL. So once you know that the axis is off, you could feed it into a online www.astigmaticfix.com, and you need to feed in what is the present astigmatism, what is the present axis, and it will tell you how to rotate it. What you need to understand, all eyes cannot get a rotation. If the spherical equivalent, +2 with -3, the spherical equivalent is nearly 0. Only in these eyes will it improve by rotating the toric IOL. So these are some factors which you need to understand. So when would you rotate? You would wait for a couple of weeks and then you would rotate these eyes, because if you wait for too long, there could be fibrosis of the capsule and it might be difficult to rotate these lenses. So essentially, what you need to understand from my talk is there is on-axis incision, which is not needed nowadays. There are limbal relaxing incision, arcuate keratotomies, which are, okay, debulk the astigmatism, but they are not very precise. Today we can do a toric IOL even from a small amount of astigmatism of even 0.75. Why do you want to correct small astigmatism? Because you want to give a good visual quality to the patient. And to do a good toric IOL, we need to do good measurements, align the IOLs. I haven't been able to describe how to align it because of the limit of time. But you need to be thorough about what you have, what you understand, and ensure that you have read about it and put it all together as how to control astigmatism in a cataract patient. Thank you.
Thank you, Dr. Chitra, for that wonderful talk. Any questions from the audience for Dr. Chitra?
You know, you can ask me some very basic question also.
Yeah.
It's not
Since
necessary.
it's Aishala, you can ask really basic questions.
Yeah. Anything you can ask. You know, when you don't ask anything, I'll have my whole day very upsetting, because that means I have conveyed just nothing to you all. So do ask something. One of you.
I hope all of you are clear which is with the rule and against the rule. Please, can you tell us, Dr. Chitra, what is with the rule? How does one look at the refraction and know it's with the rule or against the rule?
So if it is along the axis curve, this astigmatism is along the 90-degree axis is with the rule. It's along the 180-degree or in that range, it's against the rule. Okay? And what is this posterior corneal astigmatism? Earlier we were talking only of anterior astigmatism. Now we talk about posterior corneal astigmatism because we want to know the total astigmatism of the cornea. And we understand that it is against the rule astigmatism in 90% of the cases. So that small power will get added onto the anterior part. These we don't have to manually do it. All these are done by the optical biometers which we have, which does it. If not, if you are doing it on immersion biometry also, you could feed it into the online calculators, which will give an assumed, do a mathematical calculation, and it will interpolate the posterior corneal astigmatism value, and that will be added, and it will be fed into any of the formulas you want. You want Barrett formulae, you can go to ascrs.com or apcrs.com, and then you can go on to the Barrett suite, and you go on to Barrett toric calculator, and feed in just your simple astigmatism. It will give a predicted corneal astigmatism, it will give, and will tell you how to how to place the IOL, and which axis if you place, what will be the amount of residual astigmatism. So it is not necessary that you should have the latest gadgets. But when you read, when y'all are all exam going students, so when you read, you need to understand there's something called astigmatism. How do you measure astigmatism? What is with the rule? What is against the rule? What is the posterior corneal astigmatism? What are the instruments? What is the need for perfection? And how I would treat whatever residual astigmatism. In that you would have answered your entire question.